Hi, this is Dr. Paul from the Dr. Paul Show. Today I'm going to talk about treatment-resistant depression. Before I get into it, though, please press like and subscribe in order to stay up to date with the current content. So the term treatment-resistant depression is a term. It's kind of a false term, and what I mean by that is when depression is being treated and the person is not getting over it, it means it's the wrong diagnosis. Okay, because if it's a true depression, we call major depressive disorder or dysthymia, or there's different types of depression. Normally, it's very treatable with antidepressants. In my practice, if you know anything about my practice, I usually combine medications. Sometimes sometimes it's as easy as one antidepressant, sometimes it's two together. But with depression, it's a fairly easy thing for me to treat. But if I have someone with depression and they either get better but not fully better, and again, my goal is a state of I call remission, and remission means completely well. So my goal with every person is to get them fully well to no further mood issues, back to when they felt the best in their life. That's the goal with every patient. So when I get a person maybe 50% better, let's say, that's better than nothing, and it's better. And sometimes patients are happy there because at least they're not where they were. I'm not happy though, because that's telling me that there's something not right here. So why are they resistant treatment? Well, basically, because it's not the right diagnosis. Normally, it means that there's a bipolar component. There's a chapter in my new book, The Corona Protocol. It's chapter 8 on this subject. And I talk about the subject in detail, and I talk about a case, a patient who has it. But basically, there's typically a mild or a subtle bipolar component. Now, bipolar 1 is easier to diagnose. These are people who have mania. They get psychotic. Bipolar 2 disorder, we call hypomania, so they're very elevated states. They don't need sleep. They don't sleep much. They don't need much sleep, and they feel great. So they're people that are easier to diagnose. There's a statistic in medicine that's very shocking, that it takes about 7 to 10 years and about 3 to 4 doctors in order to diagnose bipolar disorder. That's a shocking statistic. I mean, why would it take so long to diagnose? Because most doctors aren't looking for the subtle variations. They're looking at black and white, and they're basically, they don't see, or they're saying, well, this is as good as I can get you. That's it. So it's not it, and you got to remember the majority of bipolar disorder is depression, or we call it bipolar depression. So bipolar depression, in a sense, is similar, or pretty much the same thing as treatment-resistant depression, in my opinion. Other doctors might disagree with me. I brought this up to other doctors and lecturers, and they might disagree, and I asked them why, and they can never give me a good answer to that, because they said, well, it's different. And I asked them, well, why is it different? They don't know why it's different. They just never had the question, and they just ignore me. So you might see some commercials on TV. There's 2 medications out that are really good medications. One's called Rexulti, and one's called Vraylar. And you're going to see on the commercial, ask your doctor about adding Rexulti to your antidepressants, or ask your doctor about adding Vraylar to your antidepressants. So why is that? Well, because in their studies, they don't say anything. They basically say, this medication is for adding on to antidepressants. Well, why would you need to add a medication to antidepressant? And what are they? They're antipsychotic medications, but they're not marketed like that. Why? Because they didn't study it for that. So they get away with saying that because this is how they studied it. And when you know how the FDA works, is that when they study a certain way, they can't go against it. So anyway, that's a long story. I can do a whole other thing about the FDA. So when they market it this way, they're also doing it because it's an easier way of selling it to doctors. So if doctors hear depression, they're more on board than if they hear bipolar, because most doctors say they're not comfortable treating bipolar disorder. And again, remember, with patients who get better with these, they're very subtle patients. There's the subtle patient that most doctors will miss. I catch them because, again, I'm very in tune to why is the person not getting better. So there's a couple examples. I mean, the one example I give is if antidepressants, they get the person better, but not fully. The other is that they're on one antidepressant. When you try to add a second one, it makes them anxious, it makes them nervous. So I take it away and I think, okay, that's not the response I expected from this antidepressant. There's got to be something else going on. So that's when I say, okay, let me try Rexulti. Let me put Vraylar in. I think this is uncovering the fact that there's something deeper going on here with this person. And sure enough, boom, it works. There's other, so the antipsychotic class, which there's many of them, Seroquel is a good one if someone needs sleep at night. It's very good medication. There's other good ones too. I can go through a bunch of other ones, but the ones that come to mind first are the Rexulti and Vraylar, because that's what that's how they market them. They also market them for bipolar 1 disorder and other, but they do higher doses on when they market it for this, and lower doses when I market it for that. So this is basically why treatment-resistant disorder is something that's very important for doctors to understand, because these patients are easily treatable. You just have to know what you're doing. And like I said, if you want to read more into this, if you want to get my new book, The Corona Protocol, I have a whole chapter, like I said, where I explain this in much more detail, and I go through a very detailed case of a woman who has this, and I go through the decision-making step by step of how to get that person into the full state of remission, which means that I got her completely well. So anyways, I hope this video helps. If you like what you hear, please share this with your family and friends. If you think that if someone you know says, "Oh, I've tried antidepressants, they don't work for me," or I get worse with them, that means it's something else going on, and that they need something else. And there's other medications I didn't mention, like Lamictal is a good one for persistent depression. So there's other medications too that besides what I mentioned, but by and large, like I said, those are the main things I use for this. My success rate is extremely high. So if you like what you hear, please share this with your family and friends. And if you have any questions or comments, please send them to me. I will answer every one of them. Thank you for listening.